So we are going to be talking about winning trust and buy-in among clinicians and families for telehealth services. So my name is Tori. I am the clinical director at Associates in Pediatric Therapy. We're a pretty comprehensive pediatric therapy company. We provide speech, occupational therapy, physical therapy, and behavioral therapy. So just a little bit of background on me. I started at APT, Associates in Pediatric Therapy. I'll refer to as APT from now on, in 2017, and prior to working at APT, I completed my graduate degree at the University of Kentucky, where I had the unique experience of being in the first cohort of the grant-funded program called LINKS, which focused on training graduate speech pathology students to deliver telehealth services and program development, specifically to target children in rural areas. So these are the objectives that we are going to be focusing on today. I'm going to tell you a little bit about APT and telehealth getting started there. So when I started at APT, it was a small company, mostly in the Louisville area, with a clear mission to grow and expand in order to reach as many children in need of services as possible. This is us. I know the text is a little small here, but it gives you a good idea of our mission. So our mission is to advance patients to their next therapeutic level, and really what that means is reaching patients wherever they are, however they need to be reached. When I joined at APT in 2017, they did not use telehealth in any capacity. But about 6 months into my time at that company, there was an MBA intern and he was delivering an employee engagement survey, and one of the last questions that he asked was, "What are your thoughts on telehealth?" And so I gave him a little background on my time at UK and my training that I had, and he said, "Well, the CEO is going to want to meet with you." And so she asked me to lunch, and after talking for a while, she asked if I wanted to help her start a telehealth program. And this was obviously best case scenario for somebody like me who had just finished this great training program. But I really didn't expect it to happen so early in my career. And I also really could not say no to that opportunity. So a few months later, we started a pilot program to determine if this was going to be a good fit at our company. We pulled together some volunteer therapists, PTs, OTs, and speech therapists, and we paid them for their time and training, and we paid them for every telehealth session they delivered. We also gathered volunteer families, and we provided 4 free sessions for them in addition to their in-person sessions. So they didn't miss out on any therapy, they just got additional sessions with us for free. We surveyed the families throughout the process, beginning, during, and after, as well as the therapists, to get impressions. And feedback was mostly positive, with the majority of families saying that they felt the sessions were effective. Most therapists said they felt that they could use this in their practice. Some families and therapists still stated that they preferred in-person therapy. Again, this is 2018, so this was a while ago. But it was enough of a positive response for us to decide that it was worth it to continue with this program. So while the responses were positive, we absolutely had a lot of barriers at that time. We had a lot of barriers to tech. We went through several different video conferencing softwares to find one that worked for us. And to be honest, at that time, most parents weren't really comfortable with that medium yet. We also had a lot of struggles with insurance reimbursement. We had a lot of back and forth determining if these insurances were going to pay for these services. We also struggled a bit with therapist buy-in and family buy-in, but this is mostly stemming, in my opinion, from exposure to the service. People had a really hard time wrapping their heads around how this was actually going to work when they were so used to an in-person session. I do have a couple of quick anecdotes here. So these pictures I took back at that time on, I don't know, probably an iPhone 7. I know they're blurry, they're not great, but they really highlight some examples to me of things that we learned from this study. The top one is one of our occupational therapists, and she was working on feeding therapy with a child, which I still hear a lot of the time people saying, well, you can't do feeding on telehealth, you know. But this was such a great opportunity for us. So if any of you have ever done anything like feeding therapy, in a clinic like ours, families have to bring food. We can't supply food to patients. So we're working on expanding their diet. And most parents, I'm not saying anything about parents, I completely understand it is hard to prepare a bunch of food before you come to a session once a week. But they're gonna swing by McDonald's on their way in, they're gonna pick up fries and chicken nuggets, and that's every single week, that's what we're gonna work on. This family in particular, it was beans and rice every week, and she told the family, I really can't expand our diet if we're just working on the same things every single week. But in this session, he was in his home with his kitchen and his stove and every food in his refrigerator, and he was able to dry scrambled eggs, which would have absolutely never come with him to the clinic. So it was great to see how effective that could be and how you can really expand somebody's diet using what they have at home. The bottom image is of one of our physical therapists, and she actually came to us during the study because she felt she had a patient that was really going to benefit from us trying this out. Her patient had a condition where he was extremely immunocompromised, and so he was not able to come in person, but he was also in early intervention. And so there's this critical window of time in early intervention where it's so important that we're seeing these children. There's so much development and so much gains to be made. And because of his severe immunocompromised state, she was not able to come into their house. And so their services they were asking to put services on hold through flu season and RSV season, which would have been 6 months. That's so much time in his birth to 3 window of early intervention. And so she set them up with telehealth, and this family was really good with the technology, which helped them a lot. But it was so great to watch a PT who we have a lot of pushback from PTs the most because they're the most hands-on therapy that we work with. But in early intervention, the model is parent coaching. And so what a better way to do that than during telehealth where you can't be there. You have to talk to the parent. And she just did such an amazing job working with this friend, and he didn't have to miss out on as much therapy as he would have if he had to stay on hold that whole time. So we moved forward with our program, and it was tiny but mighty. It was 2 therapists, one of them being me, and a school contract in Indiana where we supplemented some caseload coverage. And I spent most of my time trying to convince therapists and discipline leaders and managers, really anyone that would listen, that telehealth could reasonably be worked into their practice. It was an uphill battle for the new grad, but especially during a time when people had not really heard of telehealth, despite all of our national accrediting bodies recognizing it as a service that was effective in our fields. And then spring of 2020 came, and so our CEO, she called me into a manager's meeting, and she said she was worried about this COVID pandemic thing and how it was looking, and she wanted us to be prepared in case we all had to switch to telehealth. Most of us really thought that she was overreacting, but we still went through and updated our consent forms, sent them to every patient at the company, and 2 weeks later we had to close our doors. So we were told we needed to move everybody on to telehealth, and I was tasked with training the entire company, helping everybody move over to the virtual model and talking a lot of therapists off the ledge. We were more equipped than many due to the forward thinking of our CEO, but even then it was really a hard time to be a pediatric therapist, especially if you never wanted to do telehealth in the first place. Overall, as a field, even though telehealth was not a new concept to us, we were still unprepared. For those of us that were engaging in telehealth before COVID, it was definitely an exciting time to show families, patients, and clinicians what all was possible through the utilization of telehealth. Never again would telehealth be something unfamiliar to a parent or a therapist. There was no more uncertainty that it was possible, and that big step of just exposure, ripping the Band-Aid off, opened the door for so many families. And insurance even made incredibly flexible allowances for telehealth to be used by a wider range of families. But there was a lot of telehealth going on that was a response to an emergency and not necessarily as an appropriate tool to benefit patients the most. That was something we really couldn't avoid at the time, just based on the situation. But I do continue to feel the impact of that by therapists and families. So there were many that were kind of scarred by our over-reliance of video conferencing software. And not only that, but most of those, not most, but a lot of those insurance allowances were given expiration dates, making it seem like this wasn't something that would be useful long-term. This graph does somewhat mirror the graph that you pulled up earlier, Robert. So this is actually our exact service hours from the start of our program to now. And you can see a clear spike in 2020, a spike in 2021, and a dip in 2023. So telehealth has changed from my main focus to a smaller part of my role. I moved through a lot of different positions at APT. I went from a site manager to a regional manager and ultimately to the clinical director. So I do cover our entire therapy department at this point, and today APT serves PT, physical therapy, occupational therapy, speech therapy, ABA. We have some audiology. We also are in 3 states. We're in Kentucky, Indiana, and Tennessee. We cover local private and public schools and also contract sites. But at that point in 2020, we peaked in telehealth service hours at around 400 hours a week, which today is the size of a large clinic for us. Back then, we had such a smaller company at that time, it would have been a greater part of our overall caseload. So today, we had to have some necessary structural changes at our company, which made it so I ended up bringing up a manager specific to telehealth where she can dedicate all of her focus and time on the program. And that's kind of where you start to see the increase in 2024. That's when she came on. Now we're averaging closer to 400 hours a month, which equals the size of a small clinic for us today. I do find this graph really interesting, but I really don't think it tells the whole story here because the sharp decline in telehealth services does not represent a sharp decline in patients that would benefit from telehealth services. If anything, that volume has really only grown since COVID. This year, our waitlist peaked at 6,000 children in need of services across Kentucky, Indiana, and Tennessee. And we're not the only pediatric company in these areas, so the volume is surely higher than this. And I'm not saying that 100% of these patients need telehealth or would even perfectly benefit from telehealth. But our ultimate goal is to connect everyone with a therapist that's going to be able to help them. So why can't we make these connections easily, and especially for those who would benefit from telehealth? These are things that I hear all the time. From parents, I hear a lot about lacking the necessary technology. It is a fact that technology can be cost prohibitive for a lot of families, especially the families that may benefit from telehealth the most because of their inability to transport themselves. They may also not be able to afford technology to do telehealth. Scheduling confusion, we have to use another additional software in addition to what we use to interact with them regularly. Our software is separate from our EMR, so that just kind of throws parents off sometimes. Then insurance reimbursement, they still want to know, am I going to have to pay for this? Is my insurance going to cover it? From therapists, I hear all the time, I'm not a good teletherapist. I don't have enough or the right materials, or I can't be hands-on, which that is valid. I hear resistance on both sides, but the area I really struggle with is the overlapping area in the middle, which is this feeling of it not being appropriate. And so we hear all the time, my discipline, it's not appropriate for my discipline. It's not appropriate for my child. We've tried it before, it doesn't work, or my patient or child is too young. And so here's an example of a conversation I have all the time. I met with an occupational therapist who was really struggling with telehealth sessions. She was having to do telehealth because of personal health situation for her, but she was having a hard time. And so I sat down with her and I just asked her, can you tell me about your experience that you're having? And she said, well, first off, I just have to tell you that I don't think telehealth is appropriate for occupational therapy. And that just hurt me so bad because I told her I really respectfully disagree. As an occupational therapist, you are working on activities of daily living. And so what is a better place to work on activities of daily living than the place that you live? If you're practicing dressing, use your clothes in your home. Eating, use your utensils, your scissors, your crayons, whatever you have at home. That's the most functional way to practice an ADL. And so I talked to her a little bit. She was struggling with materials, and she was working on visual motor coordination. And so she tells me, I have this binder of mazes that I do with my patients in person, and it's really easy. I can just grab it, and I can't get it to these patients on telehealth. They don't have a printer, or I can't have them pick it up, whatever. And so I have to ask her, but you're not working on mazes. You're working on visual motor coordination. So how can we take what you're actually trying to do and modify it for telehealth? We have such an idea as therapists of being stuck on these materials that we are so used to using. Telehealth really forces us to kind of break through that and not work on the activity, but work on the target. Conversations like that are very effective, one-on-one, working through each session, each target. But that's not really a sustainable approach for every single therapist at our company that is struggling with this. So what works? What does work? What helps us to increase buy-in and momentum among our team? One of our biggest successes has been with building our team of telehealth champions. And so our primary focus is on growing a new team of therapists who are dedicated to telehealth. And the more therapists across disciplines that we can have that are really proficient and do a great job, the more we'll be able to advocate for the service to the rest of the team, and the more families we can provide it to. But having a team of telehealth therapists is not the whole picture. It's also important to have advocates all the way up through our management structure. When I started the telehealth program at APT, the only way that I felt like I could keep going and keep growing was because I knew the CEO was in my corner. And our company has changed a lot, but at this point, we have more support for telehealth within our leadership across different departments than we've ever had. And that really helps us keep pushing toward our goal. Another thing that works for us is making it easy. So the most common hang-up I see with telehealth and therapy is overcomplicating it unnecessarily. Therapists feel this need to go all high tech. They can't use their materials like we just talked about with my occupational therapist friend. We are still exploring ways to simplify video conferencing software, because that's another way that it's just another barrier for us to have ease of getting into our telehealth sessions. But that's only part of it. Making materials accessible to everyone. We have resource libraries, subscriptions to accounts with interactive games for our therapists to use. But we also, more than anything, try to emphasize that you can simplify. One of my most successful telehealth sessions that I have right now is one where I don't use a single high-tech interactive game at all. And then our last strategy is educating everybody. So telehealth education is a standard piece of onboarding for everybody at our company, our therapists and our scheduling team. Our therapists get a comprehensive telehealth training as they onboard. It covers evaluation, etiquette, session planning, billing and documentation, frequently asked questions. That's day one, so that they know this is an option for them and they know how to do it well. What still is not working? Technology barriers. So there are going to be barriers to nearly every service delivery model, but they are very obvious with telehealth, and that's that technology is not always 100% reliable. If I were to have an in-person therapy room where the lights flickered on and off or the walls came down sometimes, it would make it really hard to do my job. And I understand that that makes things challenging for therapists trying to do telehealth that don't know how to, in the moment, troubleshoot or work around some of those issues. And as I mentioned before, we know that technology can be cost prohibitive for families, so we can't guarantee that everyone's going to have a perfect tech setup. But for us, that's really the only criteria that rules them out as a candidate for telehealth with us if they don't have the appropriate internet or hardware to be able to have a telehealth session. We can't see them. Concerns about quality and relationships. There's a lot of preconceived notions about not being able to develop a strong relationship in a high quality telehealth session. So on the last slide, I mentioned a family that didn't use a single interactive game for. And she is a patient that most therapists would characterize as not appropriate for telehealth. She has autism and she doesn't really attend to me. But I work directly with her mom. And so I bring her up because she gets a lot of therapy with us. She gets speech therapy in person and with me. She gets OT and ABA, but I'm the only one that works directly with the parent, and that's because of telehealth. So on telehealth, that's a necessity to be able to develop that strong relationship. When you have an in-person session, it can be an option or an opportunity. And then questions around reimbursement and laws. Because we serve so many disciplines, so many states, we have to stay on top of all of that. Okay, so things that we are trying next. I know I'm going a little bit, I'm so sorry. Can I take like one more minute to wrap up? Okay. My husband was like, there won't be Oscar music or anything, but I can get to talking a lot, so sorry about that. So basically, we are working on marketing campaigns and exploring tech and focusing on clients. Really, the biggest thing here is that we want to get testimonies from patients and families to, again, increase exposure, normalize this. We also want to be able to explore waiver programs, ways that we can help families access technology. And then focusing on our clients and their experience, seeing if we can expand the use of hybrid models, get everybody to try this. And my last slide here is just the biggest picture. So within our company, our service hours are nowhere near that those COVID highs, but they've also started to tick back up, which is very encouraging to me. And there's a lot of policies and opportunities here to continue to improve access with telehealth. if we are able to keep moving in a positive direction. So CMS, again, where it may not directly impact pediatrics, but it does, in every state at least, it does have the potential to set the tone for how telehealth is viewed and whether or not it's continued to be seen as an equivalent service. Interstate compacts help us have affordable licensure across different states, and since we serve in many, this is important for us. And then advocacy and opportunity. So the more we have trusted voices speaking on behalf, it'll lead to more positive experiences with families and therapists. This, to me, is the most important step toward reaching this model's potential and breaking down more and more barriers to access to care. So we're just one company in the broader landscape of a society that's just trying to refit telehealth back into their normal lives after those major pendulum swings that happened from COVID. So we have a lot of areas to grow in, and it's my hope that continued education, advocacy, and exposure can eventually help us to reach more families that would benefit from the service the most.